I'm excited to introduce Amir Dan Rubin to everybody for our 41st CEO Leadership Series interview spanning the last 4 years. Amir is the former COO, CEO of UCLA Medical, Stony Brook Hospital, Stanford Health Systems, divisional CEO at United Healthcare, former CEO of One Medical that he sold to Amazon, and now the founder of the AI healthcare focused venture capital group, Healthier Capital. So, Amir, you've been busy.
Great to be here with you, Roy, and the group. So thank you so much for having me.
Oh, it's our pleasure. So, a lot to cover. So, I'm going to jump straight in. Your unique experience and the many different ways to dissect it or to look at it. I'll start with for-profit versus non-profit, a large theme across US healthcare. Your vantage point at One Medical for-profit, your vantage point at Stanford Health, UCLA non-profit. How do you think of those two terms from a managerial decision-making perspective?
Yeah, well, first of all, Roy, great to be here and great to be with the Scale Healthcare community. So thanks so much for having me. I think to kick it off from a managerial perspective at some level, personally, I managed the same across those environments. I think in any environment, one needs to understand one's stakeholders. Um, and of course, understand one's mission and business model. The stakeholders are similar, but slightly different across nonprofit and for profit. We all have common stakeholders, if you will, across nonprofit and for profit on the demand side, who are our customers and clients, whether it's patients or members, or if you're in a health plan, employers or intermediate members. And we all have our kind of supply side issues, our clinicians, physicians, if we're in care delivery, our coordination with health plans and others. So I think that part is reasonably similar. Where it starts splitting off is on, as we all know here, on the for-profit side, we often have some level of equity investment and fund our companies through equity. And on the nonprofit, we really fund our companies solely through debt. We have tax exempt debt that is quite advantageous, has tax advantages, and that's how one finances growth and capital needs. And on the for-profit side, we could use both debt and equity. And so, those are the key foundational differences. And managing equity holders may be the key difference, and equity holders' interest in having a piece of earnings ultimately is different. But otherwise, from a day-to-day management perspective, I think operationally, I have worked in the same way. And then in terms of thinking about the broad stakeholders, reasonably similar.
Well, beyond the tax advantage debt, the other stakeholders, the philanthropic stakeholders, the government programs, is there inherent greater complexity in the different needs, different push and pull that you see in a nonprofit that affects how efficient decision making can be? Or is that just an outsider looking in? I'm focusing on the question of efficiency. Which entity would you expect to move quicker? A for-profit health system or a non-profit of equivalent size?
Yeah, that's a really great point that you're getting at. Um, I think it's possibly the case that you may have more efficiency in for-profit organizations. And I think, if that's the case, it's often due to the focus of the organization and going back to the missions and the stakeholders. I've worked in 4 academic medical centers. I was the CEO at Stanford University's health system, and as you mentioned, and COO at UCLA's health system. And there, in addition to patient care, we had missions of teaching and research, and big missions. These were, you might argue, even bigger missions than patient care, depending on the organization. And so that creates complexity in your execution. And that might make you choose service lines or make decisions that may or may not be profitable, but they help support a different mission. I'd like to believe, however, that you're trying not to do that inefficiently. If you want to train residents and medical students, you want to train them well and efficiently. If you want to do research, you want to leverage the talents of people's time and do it efficiently. But it does create complexity. And sometimes those missions have overlapping concentric circles. And sometimes there's parts of them that can be, if not in opposition, in tension. So I do think that's fair. The for-profit organizations sometimes tend to have more focused missions, and that makes it easier to align internal to the organization, because the internal stakeholders may be more aligned on what it is we're doing. Whereas when you have these broader missions, for example, teaching, research, and patient care, some people may be aligned more with one mission or the other, and so they may not be driving all in the same direction always, and that creates complexity.
So I view the health industry in the US as almost musical chairs that we get to play as a society whenever we run out of other things to complain about. And so the chairs are occupied either by malpractice lawyers, who no one's mentioned for the past few years, overpaid hospital executives, the oligopolistic payer community, private equity firms that are money-hungry, profit-oriented animals, or for-profits, period. Just any business in healthcare that is for-profit. How do you view that machination that takes place across our journalistic, regulatory spheres, given that you've seen it all, you've managed it all? Is there any truth? Is there systemic dysfunctionality in any of those actors? Is there a better way to own and run healthcare assets in this country, or is it entirely misdiagnosed? Are you seeing similar focus on patient care everywhere, but issues such as local geography, complexity in scaling these organizations, just the inherent complexity of providing care as being the fundamental issue?
Yeah, well, I see your journalistic chops coming through here, Roy, in the premise and setup of this question. So let me go back to the initial premise. I am more the optimist on how I look at the various parties and stakeholders in the health system. So I might not have set up the premise in the negative per se about the motivations and incentives of these different stakeholders leaning towards the negative. Having worked across different platforms, in general, I've seen smart, patient care oriented, committed folks that want to succeed. They want the organization to succeed, and they might want to personally succeed as well. But I would take the first premise as a little more in a little more of the positive. And at some level, people are working within the system that we have, right? Even the nonprofit people, the nurses and doctors, or the for-profit in organizations, the nurses and doctors. I mean, in general, I believe they're trying to deliver great patient care. They care about what they're doing, but they're working within a system. They get paid a certain way. They have certain time constraints. They have certain technology systems they have to use. And it's often hard for people to redesign their system when they're in the midst of a system. It's not as if they don't necessarily know some of the problems of the overall system, but often it takes multiple parties across those stakeholder groups. Well, if the reimbursement was slightly different, then I could organize my operations different. I could probably pay my people differently. Then I could spend a different amount of time in my clinic sessions. I could maybe follow up in between sessions because there's economic models around that. But if those don't exist, what am I going to do? How am I going to do this in the best way I can? So I think at some level we're operating within a system, and our system changes, the healthcare ecosystem broadly, but it tends to change gradually, given general conservatism about blowing up the healthcare system, given the multiple stakeholders and health policy issues and political factions and the rest, and the various actors, whether it's life sciences companies, pharma, med device, whether it's insurance or care delivery. And those things are, to make change, you often need to move things simultaneously. So that's hard to do. However, we do see across these entities better performing entities. Some organizations have higher satisfaction scores. They have higher employee retention scores. They have higher quality scores. They have higher financial results. Sometimes I would like to believe, often these things are correlated. The better managed organization tend to have good results across all of those things, even working within our current system. And then moreover, you have organizations, whether it's startups, like a lot of the ones that Healthier Capital is investing in, or ones like One Medical that are saying, I'm going to try to disrupt the system, probably from within it. I have to understand that there's insurers and Medicare and Medicaid and commercial insurance and all these other actors. But I do think I could try to do some things differently. I could innovate with technology. I could maybe think about different care delivery models, or revenue models, or compensation models. So you do see differences. You do see a distribution of performance across parties. So I would, going back to your premise, I would spin it positively, in the sense that people in general, I believe, are leaning towards wanting to deliver great results. You do see differences between organizations, and they're managing within a current ecosystem. And a few of them try to redesign that ecosystem from within while running an organization in that ecosystem, but that's hard to do.
I'm glad you said that. I also push back on the broad brush prejudices. I think they're misplaced. So digging into this, the actual names themselves, you've run very large, the largest, medium size, and now you're focused on the small new entrants. So the question of the benefits of scale, I imagine, is very near to you. As you think about, actually, before I even ask the question, you've worked for the largest of the payers, some of the largest health systems, one of the largest aggregators in primary care, the largest of the tech companies, new age tech companies that ventured into healthcare through Amazon, and now exposed to all these high energy, vision orientated, exciting startups. Which of all these organizations has really stood out for you that you look back on with nostalgia as they did it right? They had the right culture. They built great infrastructure. They were almost outperforming. And when you think about almost Jim Collins' good to great, the great, which of them would you point to first as great?
Well, these are different organizations, the ones I've worked in, and I love all my children equally. So,
oh my God, you should run for office, Amir. Let's get real.
Well, I think they're different. Let me start with my most recent role, which was One Medical. And One Medical was a modernized primary care organization that combined a few things that were pretty novel. So in primary care, parts of the problem statement we like to say is all the stakeholders are frustrated. On the demand side, people are dissatisfied with the experience, largely because of access and wait times in the service experience. Employers or payers are frustrated, largely with rising costs. And then on the supply side, we see high levels of burnout, 68% levels of burnout in family physicians, and uncoordinated care. And so at One Medical, we said, we know these are problems, and having very short visits, paying providers on a fee-for-service basis in a HSA high deductible world where every patient has first dollar payment on asking any question, probably is not the right setup for primary care. And so at One Medical, and frankly, we did the same at Stanford when I was there, and at a little bit, I'd say the same at Optum. We said, well, that's just not the right setup for primary care. So how do we address some of these problems? So on the demand side, starting with the consumer, we said, well, what if you can ask any question, consumer, anytime on an app, asynchronously message, get prescriptions, or have a synchronous video chat, and we won't charge you. We won't bill you for that. Would you like that? Yes, we'd love that. So we did that. Now we need an economic model for that. We said, what if we charge you a membership fee? So we can kind of get some revenue for that. It was hard to contract from payers that. So we said, what if we ask the consumer if we'll pay that? And then we said, what if we went to employers and said, hey, why don't you pay this for your employees? And that's what we were able to do. Now the membership fee is $9 a month. You could get it on Amazon Prime, add it to your Prime membership. So, and then we went to large employers. We signed up 9,400 employers who were offering One Medical as a benefit. And so now we're able to say, okay, we have kind of no copay, no deductible, no claim, ask us a question anytime. But we have a little modernized revenue model around that. So now we're fixing that. Hey, why don't you come to primary care first? Let's make that really financially easy. And then we thought about the other aspects of access. You could do it digitally. We'll put locations in retail locations across the country. We'll have same and next day appointments. We'll have a very high 90 Net Promoter Score, high service experience. So we solved for some of the problems that we knew with primary care on the demand side. And then on the supply side, we said, gosh, if we take these providers and they have unlimited video chats and messages, and we pay them a fee for service, but there's no reimbursement here, that's not going to work. So why don't we pay them a fixed salary? Let's make the appointments longer, 30 minutes in office appointments, and let's build a virtual team. And this is kind of before the whole COVID pandemic, we had this model, and then it played well during COVID. And that virtual team, let's use software, natural language processing to read messages and then route messages off of the in-office provider inbox. And then we'll have 24/7 team members respond to these other messages. So we helped improve provider burnout by having salaried model, longer appointment. We took about 55% of their tasks off of them in office, routed those somewhere else. And then, by the way, to fit into the ecosystem, we accepted insurance. We accepted commercial insurance. So there we were solving for kind of what folks knew is barriers to access because of copays, deductibles, wait time, service experience for the consumer side, and burdens on providers and non-value-based care in a fee-for-service, short visit primary care model. So let's have salaried model, let's leverage tech and have more time. So I think that was clever innovation, both on the service experience, on the care delivery experience, and then building an economic model that can work there. Going back to your initial question, why I can't compare that across is, if you go to a Stanford or a UCLA or a Stony Brook, we were running ORs and ICUs, and it's a different level of complexity. And of course, at United and Optum, you're running an insurance business, and I was on the Optum side in the care delivery side, mostly in behavioral health. So they're just a little bit of apples and oranges. But what I appreciated about what we were able to do at One Medical is we were able to innovate kind of from within the system. Kind of that back to your earlier question. It's hard to innovate from within the system and operate at the same time. That's what we were trying to do.
The One Medical case study, let me see if I get it right, because I think there's so much value in it. But before I unpack it, I want to know that I understood it. It feels to me from an outsider looking in that the premise, whether intentional or accidental, was we're going to focus on the corporate space, on-site, off-site. That's our primary audience. And we're going to do a few things innovatively much better, but not much more than that. And those few things are going to make a real difference, whether it's virtual care or or patient service. We're going to provide high quality, highly reliable, as you said, asynchronistic communication that is effective. And I speak as a firsthand case study of One Medical working. I've been a One Medical patient for many years and have loved the experience because it is highly reliable care, consistently high quality, and the customer service is extremely high. And am I right in saying the experiment that more or less defined it, as opposed to the incredibly complicated efforts from the Oak Streets, Kanos, Village MDs to try to create this concept called fully coordinated care that was monetarily driven, economically incentivized, coordinated care, very different. Is that accurate, or am I missing something?
I would say not exactly accurate in the sense that you are accurate in the sense that we had to think about the patient populations and also what were the revenue and economic models. And in commercial insurance, there isn't a lot of global capitation. But we built a model for value-based care that would have done great in commercial global cap. We had salaried model providers. We had 90th percentile HEDIS scores. And by the way, we did publish a paper in JAMA Network Open that showed, at least for one employer, we took down their cost 45%. And so we were absolutely doing that. But, and I'll note, we then were serving people over 65. And we said, gosh, there is a model where we tend to take capitation. And so we did the same thing. We actually bought a company called Iora Health, which is like an Oak Street Health or ChenMed or what have you. And we took global Medicare Advantage capitation. And then we started blending those populations in certain clinics and certain geographies. So we actually did both. So I would say our clinical model was a value-based care model. Just in commercial insurance, there isn't global cap to be had, but we needed a little cap. We were doing more things. We were following up with patients. We had custom at, we had 24/7 coverage. So what did we do? We made up our own cap, the membership fee. In the Medicare space, we did take Medicare Advantage. Actually, last year on ACO Reach, when CMMI reported out the top performers, we were number one and tied, if you will, number 1 and 2. It was One Medical and Oak Street in terms of savings. So no, I would say we built the right model for coordinated care. One just has to think about the commercial revenue model differently across the different payer categories. And I think we did that well. So I think the difference was, I'll flip it the opposite. Most people haven't figured out a way to make money delivering highly coordinated primary care in the commercial segment, because commercial pays fee for service. And actually, that's a worse reimbursement when you're doing a lot more. We have free on-demand 24/7 asynchronous chats and video chats. We do outbound outreach on our complex patients, and we have no revenue model for that in commercial insurance. We made one up and we said, let's charge a membership fee. So I would say we're actually doing something similar, just trying to fit it into the commercial insurance world.
Yeah, but where I would push back on that is I'm not sure most people have figured out how to make sustainable, healthy margins in the non-government portion either. And so I never got the sense from One Medical that it was a cheap capital play the way that Oak Street and Kano have been. And I know there are exceptions, or at least there were exceptions up until the last 12 to 24 months of healthy margin, high growth, MA focused, complex global cap outfits out there. I think ChenMed, maybe Apollo, but maybe certainly the more narrowly defined market-orientated groups that drove growth based on ethnic focus, market focus. They seem to outperform because they were able to get even better results out of their patients and providers. But for the most part, and you hear this time and time again, that the presumption is the MA space is incredibly difficult to pull off from a return on capital perspective. So I think you sort of dodged both bullets by doing what you did. And that tells me that you built it differently. Is that fair? I mean,
Well,
you were on the inside. I'm just looking from the outside.
well, I think we did things differently. That's fair, but let me take a step back on the Medicare Advantage space. I did have responsibility for the capitated medical groups at Optum. As I said, we were with we bought a company, Iora, and I'm colleagues and friends with folks who run some of those other great organizations. Is Optum getting out of the care delivery business? Have you seen Humana get into capitated groups? You just saw Elevance announce that they're doing something with CD&R to bring in groups. Actually, these groups can work really well. And if you look at the performance of cohorts, for example, at One Medical Seniors, after a few years, we were down to, call it 70% medical expense ratio. And again, the plans were keeping a chunk, their administrative ratio off the top. And you saw similar performance at Oak Street and others. So the thing is, each time you bring in a new cohort of lives, in year one, you might spend 100% of that claim's expense. You're accountable for all their expense. You haven't yet managed their cost. You haven't been able to deliver care. But over years, that goes down. So you are right. That is, as you grow, that's capital intensive because it takes, call it 3 years to get that performance. And when the stock market shifted and capital costs went up, that made it harder. There was also some shifts in how Medicare was paying health plans and thus groups in terms of stars, quality rankings, in terms of risk adjustment factors. And you've seen that in the both health plan market, and that flows through to the care delivery. But actually, as you see the organizations that sit on both sides of that, they've doubled down. If you're the health plan on one side and the care delivery, because you have that expense anyhow.
Some have moved away, right? You've got examples of super large cap entities that have shut down their exposure to the space. So there's examples of both, and I take the point that these groups look for vintage. Will they find them over time? And you would know better than me because this experiment has been going on for quite some time, but it is at least suspect that large groups have run afoul of return on equity. Large, well-capitalized, multi-state, national entities with real scale, multi-billion-dollar revenue streams, and they're generating hundreds of millions of dollars of losses. And that, again, if you can skip that, if your growth at One Medical is incrementally positive, year-on-year returns, sustainable, then it is a lower risk business model. And you're almost being too kind to the Deweys, DuPages of this world, the Village MDs, and of course the Kanos and the Oak Streets. You're being too kind.
No, I would say there's apples and oranges in those groups, and you can't, I think, lump every care delivery group together. Execution is hard. If you dig into any one of those individual companies, some have done very different strategies, and ultimately, it goes back to one of your initial questions. Execution matters, and execution is going to be a big part of this. And again, some of these folks said, hey, we're going to buy a bunch of stuff that aren't going to be integrated. We're going to grow like crazy. And then the capital markets change and you're burning a lot of cash. And others were saying, wow, we built really consistent tech systems, clinical systems. Regulatory rules might change. That might impact reimbursements, but actually underlying performance is strong. So I think back to one of your other questions, execution matters. Back to your other question, focus and consistency matters. And then again, these are very tough, right? Businesses, and there's different economic models that are needed across commercial, Medicaid, Medicare, dual eligibles, and you've got variations in kind of those strategies across different organizations.
Yeah, I mean, the other direct primary care business that we came across, Premise, very successful. The only real obstacle that threw them off their otherwise quite stable growth trajectory was COVID. Other than that, sustainable, repeatable, scalable. It feels to me, again, as an outsider, primary care looking in, if you have a truly rational winning strategy, definable, and it works. It's not speculative. It's not awfully difficult to execute upon. Another example, I'm partnered with the largest health system in my state. I represent them. Their HOPD enhanced rates are available to me. I have an opportunity to scale well in my state, therefore. Those strategies seem to work in primary care. What I wrestle with is we have solved for coordinated care, because it seems to me that those who have built around that concept alone, I'm going to risk stratify, I'm going to create my patient pools, I'm going to go out and I'm going to scale that business. I just don't know that that's been as successful yet.
Yeah, I think a few things, as I sometimes like to say, which is not a genius insight. Risk is risky, right?
Yeah, that's the statement I was looking for from you. That's the one.
Yeah, risk is very risky, right? And then one is taking global risk, and then a new drug comes out and you have pharmacy risk, or Medicare changes the way it's reimbursed, or your population shifts. You need actuarial and risk management capabilities as well as clinical capabilities. So these are really hard things to do. Like, these are hard things to do. I'm, however, happy that organizations are trying to take on these hard things. Yes, these are hard. And then even if you've got the strategy and the finance conceptually right and you manage that perfectly, the execution is still very hard. These are very complex patients. And going back to, one of the things you asked about, which organization I thought was most differentiated or successful that I've worked at. One of the things we tried to do at all of them is leverage a consistent operating system. So kind of the way I've led and managed in each organization has been the same. It also goes back to your initial question, like, what's it like working in these? Well, I frankly managed in the same way. And I think about, how do we do what I call strategic alignment and deployment? How do we know what our mission and strategy and goals are, down to all of our metrics and dashboards? And do we agree that these are the things we're working on? So I'll call that strategic alignment and deployment. We all do some variation of that. The second part is improvement and innovation. Great. These are our goals. We want to improve. We all agree these are the areas we're working on. Who's doing what by when to make this better, and how's it going? And how do we do that in a multidisciplinary way? And kind of the third bucket where often I see organizations fall is what we call active daily management. It's great to have goals. It's great to improve upon those goals. But what do we do each and every day, always, to sustain and scale that performance? How do we hire? How do we onboard? How do we train? How do we build, in lean parlance, the standard work? How do people know each and every day how to do this particular task and activity? How do we go and view and observe and see what's happening in the field? Do we do that regularly? I think having these kind of approaches are key to execution. And then, yes, one might succeed or fail based on strategy and financial models and the risk, the riskiness around that. But even within that, you have wide variations in execution and performance, because this other part is really hard to do in healthcare. I mean, all of your members are running complex organizations. It's very, very hard to do. And, some organizations do it better than others.
I couldn't agree with you more. And my point in trying to delve into this topic is to try to evaluate the terrain accurately, not with a goal of judging it. In fact, quite the opposite. My view is the health of an industry is defined by one of the ingredients is the frequency of failure and the type of failure, which is the last thing that regulators ever want to hear, because they're afraid that they're going to get blamed for it. But you can't have a healthy healthcare industry without assets attempting what seems like the impossible, and in many cases failing because it's hard. So I'm with you. But if coordination of care is a critical driver and determinant of success in our industry, how coordinated are we really? And if where we've been is a paradigm of staggered meal, you have part of your lunch is served to you in the morning, and part of that lunch is served to you in the evening, and you're left wondering, was this ever a lunch at all? And that's sort of a metaphor for healthcare today. It's not really coordinated. It's siloed. Where do you think we're heading? And I wanna bring us to healthier capital and the focus on AI in healthcare and your investments in the space. Why are you and others like Eric from the advisory board, why are you so excited that we really are now entering this new age of truly coordinated healthcare?
Yeah, Roy, there's great points. If you ask the key stakeholders, do you think your care is coordinated? If you ask the consumer, they're telling us no. If you ask the employer who's paying for it, or even the government payers, they'd say no.
Yeah, it feels like you're getting your lunch, tea, and dessert 3 days later.
Correct. The interesting thing, though, is if you ask providers, they'd say no as well. Look, I'm just trading water to keep up with what I'm doing. And it's very hard for me to get referrals, to get authorization, to coordinate that care, to follow up between appointments. So absolutely, I think that's a problem statement. There are instances, however, where we do this well, whether it's some aspects of the primary care models we discussed, or, for example, maybe a patient's got a complex condition and I'm within this specialty and they're doing a great job between the surgeon and the doctor and the nurse and the radiologist. Often those are very hard to coordinate as well, but sometimes you see programs, cancer centers and others, that put a lot of effort into coordinating that care. So you have instances of it, but in general, it's hard to do because, to use your other word, we have built our system into silos, into specialty silos that get reimbursed for, their encounters or engagements. So this is an absolute area that we're looking for innovation in, because every stakeholder is frustrated here. So if you can find innovative models, they can disrupt from within. They can have an impact. And maybe just to share kind of a few examples of the types of things. For example, we're looking to invest in a agentic AI, conversational AI agent. Agentic meaning agent. So that can help. Right now, it's working with a number of health systems. And people can talk to it, they can message it, and it gives you the right answer. Where do I go? How do I schedule? I'd like to rebook an appointment. Can I get a prescription renewal? And this can take information, whether it's from PDFs or websites, and it can basically always give you that answer, as opposed to the turnover in the contact center and you have sticky notes on your computer screen. This can do that. This is not going to be the end all and be all of all coordination, but sometimes the front door, whether it's the web or the phone, is hard to get through. Your answers are hard to get. So that's an example. And they're in some health systems now where they're handling 85% of the contacts automatically with really, really smooth service experience. So there are, and then this organization and others like it are then saying, well, what other follow-up tasks can we take off the humans? Well, gosh, before the specialty appointment, it doesn't make sense if you book an appointment and you got the wrong physician, or I can't do much. I was just with a neurosurgeon here we were catching up in New York City yesterday. And he's like, yeah, I get referrals of patients that come into my office. I'm not actually specialized in their area and I have no images. I really can't do anything. It's kind of a wasted appointment. And they might have waited months to see me. Well, that's a waste. That we can solve with, for example, innovative software. So let's make sure what condition does this person have? What information would we need in advance of seeing this patient? Those are the kind of questions that technology can help us with. Just a couple of examples.
It's interesting that while our industry here in the US is 17.5 million labor strong, it isn't recognized as a world leader. I wonder how our reputation will change when we are front foot technology as an industry, as a US healthcare industry. And I do think you have to assume that 10 years from now, the entire branding of US healthcare might change when what we lead with is not the size of our labor force, but the strength of our technological innovation within healthcare. Hasn't happened yet, but it's happening. And that's really interesting. Why is the answer not, well, Amazon and Facebook have gotten this taken care of. Don't worry, Amir, focus elsewhere. Why do you feel that the opportunities still exist at the microcap level, despite the presumption that these behemoths are out there buying, acquiring anything that sniffs of any value whatsoever? Or are you counting on that?
Yeah, a few ways to answer this. I think, first of all, in applying technology to healthcare, but probably true in applying it to aerospace or consumer or banking, financial services, one needs to understand that ecosystem. And healthcare's ecosystem, as we've been discussing here today, is complicated. How does it work in Medicaid? How does it work in Medicare? How does it work in commercial insurance? How is that AI being managed? Does it need FDA clearance? It might. One of our companies uses AI in imaging to reduce the time in an MRI scanner in half. Pretty darn useful for increasing throughput. That went through FDA clearance. Other AIs don't go through that. They're more decision support. So the healthcare situation is complicated. If you're going to be making medical decisions, are we making sure, we didn't drop a zero off your lab results? That might make a difference, right? So I think, first of all, one needs to navigate the healthcare ecosystem. And that requires understanding how healthcare works, understanding the regulatory environment, the clinical environment, the various stakeholders. And so that could involve large tech companies getting involved, and they are, whether that's building foundational models, whether it's hosting cloud services, but it's to this point been very hard for them to get into the idiosyncrasies of these healthcare organizations, and frankly, it may not be the best business model for them. It may be much better to just sell cloud services to all of them and like, you know what, you all folks in healthcare, you figure out the next level. We'll just sell you storage or compute. And that's a mass generalization, but in general, that's where you've seen kind of the big tech play, frankly, which may be the better business.
I think that's very interesting. It's a massive aggregated market, healthcare, but it's arguably the most fragmented of all markets because of its idiosyncrasy. It really is a million tiny markets that add up to one whole, and I'm not sure that is an easy opportunity for a $1 trillion business to explore, but rather a wonderful opportunity for many niche players to explore. It's almost as if you're describing an impossibly difficult coded pathway to growth that you have to do in order to discover. Like no one really knows how to scale new entry AI in healthcare. You have to do it and learn what works, what can scale as you're doing it.
Yeah, and just a couple other examples to that point. So I talked about this kind of agentic AI kind of customer service agent. That could potentially have a broad base. It won't solve every problem in healthcare, but part of why that is working so well is it's got interfaces to Epic and Cerner and Salesforce. It has interfaces into your phone system via NICE, Amazon Connect. It needs to work across your patient engagement systems. And there's multiple organizations here. It needs to work across the big tech players. And so sometimes being one of the players is hard to work across all of these players. So it's not just the AI, but it's how it interfaces into the ecosystem. We have another company that's automating kind of the clinical research. It's using the same kind of agent approach to do autonomous research. It takes electronic health record data, and the researcher can ask in kind of natural language, how is this correlated with that? And the system on its own will say, well, to answer that question, let me set up a control group, an experimental group. Let me ingest this data. Let me look for outliers and let me run statistical analyses. And here's an initial finding. That's learning from researchers. Well, you have to understand how researchers work. You have to understand how to build a neural network that can learn from them. It's not just about raw data. It has to understand, okay, and then I want to write that up into an NIH grant application. So you have to understand NIH grants. And then I want to write this up into a paper and submit it to JAMA. Well, you have to understand those rules. So again, that's a very exciting company, by the way, that can do that end to end. But you need to understand each of those steps, each of those rules. And by the way, each of those steps and a lot of those rules keep changing. And so this is where breaking down, the $4 trillion health system in the US, and then you get into global health system down and into its subcomponents is important.
I want to open it up to the rest of the group. If you have any questions for Amir, feel free to ask them now.
Hey, it's Margaret. Excuse me. Good morning.
Good morning.
Amir, thank you for coming to speak with us. It's been extremely interesting. My role within Scale is payer strategy, contracting, and regulatory research. I have a couple of questions. I'll go ahead and put them on the table and then ask you to answer them as you will. So the first question has to do with your experience that you referenced while running One Medical. And that was one of the groups experienced a 40+ percentage reduction in cost. Was that primary cost or was that total care, cost of care? And then if it was total, how were you managing sort of those downstream services and costs? And then secondly, I heard you say you worked in behavioral health with Optum. What do you see happening on a national stage with behavioral health?
Yeah, Margaret, thanks so much for those great questions. So on the first question at One Medical, and we mentioned this study that we had in JAMA Network Open, which showed that we took the total cost of care down 45%. So that was total cost of care. And what were the underlying mechanisms? Well, at some level, by having that easy access to primary care 24/7, including no copay and no deductible if you had a question, that averted a bunch of emergency room visits. I think it was something like 35 to 40% reduction in ER visits because people can come to us. And then, by the way, once you go to an ER visit, you might have diagnostics, you might have lab work, you might end up in observation care. Doesn't mean we wouldn't send people to the ER, but we can often answer their question quickly. The other thing we could do is we could get them into same-day appointments and next day. Well, why don't you just come in? Let's see you. So that was one of the underlying mechanisms. Then once you're in primary care, typically, and I've worked in great health systems with largely fee-for-service primary care with clinicians working really hard, they don't have a lot of time. And so if you have a lot of issues, we end up referring you out to specialty care. Well, we had half-an-hour appointments. We had longer time. So we can handle a lot of the CHF, COPD, behavioral health issues in primary care. And so we started then seeing also like 30, 40, 50% reductions in referrals. And again, our providers were straight salary. There was no incentive for them to reduce referrals or increase referrals. They just had the time. And then our technology, we defaulted into generic drugs. Whatever was written, the generic would come up. The clinician can override that, but they typically didn't. So we had really high generic drug usage. So we were able to reduce specialty referrals, reduce ER visits and hospitalizations reduce specialty care, have higher generic drug usage by having kind of easy, accessible, salaried model primary care. And it took down total cost of care. So that was that. Now, to your second question about behavioral health, huge problem in the US, a lot of demand, not great access. We were actually invested in a couple of companies in behavioral health, one in telebehavioral health that takes therapists, puts them in an MSO model, takes insurance, and builds interesting software layer to help manage their practice. And then we have another business that is focused on serious mental illness. These are patients discharged from inpatient psych units with schizophrenia, psychosis. And they're the issue. They've built a complex care, multidisciplinary medical home, not just with psychiatry, psychology, peer support, but also primary care and long-acting injectable meds. And they're showing they can take readmissions, 30-day readmissions in this population are over 25%. This organization is close to zero. And so they were able to go to health plans and say, hey, I'll save you 30, 40 grand next month on avoiding readmissions, and have found an innovative model there. So I think you have, just like in other specialties, mental health is a broad area. So you have certainly general anxiety, stress, depression, but also kind of Pareto rule in effect, very high cost on a smaller percent of the population and serious mental illness.
Okay, thank you.
Thank you. I do see some questions here in the chat. Roy, should I go to those?
Yeah, we could. I will go to those, assuming no one else wants to ask a question live. Yeah, so we have a question in the chat room regarding, I think, how to evaluate AI holistically. What for many of us who haven't used AI yet, adopted it, integrated it, it's a scary proposition. Anytime you do something for the first time, you're far advanced in AI in healthcare. On a relative basis, you're a black belt. But I imagine you're also learning every day, as is everyone involved in the space. But given what you've seen so far, what are some of the most important questions that you would recommend others ask?
Yeah, well, I think at some level we're in early innings, and I would not put myself as a black belt in a field that we
That's why I said relative.
that we don't even know exactly where it's going. So I think the first thing is thinking about safety, security, almost compliance. We're investors in a company in the space that's just trying to do that. If you're going to use the AI model, how do you know what data it's trained on? How do you know it gives you consistent results? How do you know it doesn't have drift, or the model changes over time? How do you know it doesn't have bias in the results? How do you know if it's taking your data, ingesting it, and selling it somewhere else? How do you know if it's taking your PHI and PII? So these are, and this organization is working with health systems on helping answer those questions and then track and monitor these systems. So I do think this question of safe AI use is going to be important. So for example, the other two AI companies I mentioned already that we're investors in, one in kind of, or about to be on this one, on the agentic AI, the customer service agent, they have a lot of effort around safe and secure AI. For example, they're using kind of these large language models to understand the voice, but then the answer is not just coming from general web data. The answer is the data you gave it. It will only answer the information you gave it. And then it could use LLMs to speak that back or to write you a follow-up sentence, but it's not going to make up answers. And if something isn't immediately answerable, it won't guess. It'll send it to a human. So those are the kind of controls one might want to look for. Now, if something is in, customer facing or clinician facing, you may need more controls versus like, hey, I'm just doing a general search. I want some information on something, and that's where folks may go to ChatGPT and others and get really interesting answers, often like really great answers. But by the way, if you type the same question 2 or 3 times, you'll get 2 or 3 different answers.
Yep.
depending on your topic, like what floor should I park on in the parking lot for this clinic, you want the same answer, right? So thinking about that safety and security is important. Thinking about what's happening with your data. It could be okay, by the way, if the organization takes your data. Some of these models are trying to take data and sell it to life sciences. That can be fine if it's anonymized, if it's secure, but just understanding, I think, what's happening there is important.
Very interesting. It's almost like we need to create a different type of AI, medical AI. You know, I think about all the conversations I've had with AI, and I point something out, and the chat GPT response is, "Oh, you're right." And I'm thinking that probably doesn't work in a doctor's office. Doctor, I think that I have, I swear I have cancer. Oh, you're right. Probably not the right response. So these different levers, the personality of AI needs to replicate almost a human clinician that is pre-trained over years to say, in that situation, that's great that you feel that way, but here's the science.
That's exactly right. And also, what hasn't been said? This is where humans are really good. Okay, Roy's describing this, that, and the other, but like, I think he's holding something back.
Hypochondria.
Yeah.
In my notes.
Right. That might be the most important thing. And so I know, Roy, we looked, and you had seen a demo of one of the companies we're looking at that's kind of a AI support tool for office-based physicians, like many here. And basically what it's doing is, as the patient and physician are having a conversation, it's basically taking textbook knowledge and saying, hey, this sounds like it could be this or it could be that, or let me document this because I heard you say this. And then later on, the clinician can confirm or reject those things. But at some level, it's just doing like quicker search or faster documentation. I think these tools might look like they can diagnose because you've loaded up every medical textbook into them and they can give you answers. But again, it's the humans that are going to be needed, what hasn't been said, or, all right, these are 4 things it could be the case. Each of the treatment paths have different, side effects. There are different complexities around them. What's the right thing for the human? So I think we're going to need to be both technology powered, but also human centered.
I think that's so appropriate. I'll finish off by saying I saw a pain doctor yesterday for my neck, and she spent an hour and a half talking to me. And while she's prescribing pain medication, I know that she's looking at me thinking, is this the kind of person who's actually going to take the medication the way that I prescribed it? Or is he likely to just take one pill and I can see her mind evaluating what kind of patient am I? So it's just interesting, all the subtle intangibles that add up to smart medicine. Amir, I want to thank you for this morning. I thought it was highly and uniquely insightful. I'd like to say I was surprised, but I think it's as I expected. And I look forward to staying in touch and working with you for years to come. Thank you.
Roy, thank you. Thanks to the Scale Healthcare community. I appreciate what all of these leaders, what you're all doing, running really, really complex businesses, trying to make healthcare happen out there. Thanks for having me.
Thank you. Good day.